ourselves.
Okay.
Hi, my name is Rasoul.
And I am Mohammed Haddad.
And we're third-year medical students. So we're going to give you guys an overview of anatomy questions. We try to compile about 3 questions per lecture. But at any point you guys you have a problem with anything that we're explaining, or you have a problem with a certain lecture that we didn't cover, you guys can stop us either by the chat or by unmuting yourself. Okay, so we want to make this interactive as much as we can. So if you guys can unmute to answer questions, or if you guys want to unmute to ask questions, we're more than happy to do that. So first of all, how do you guys feel about foundation / heme? Not good?
Amazing.
Okay. We tried, so Abdulrazak and Shahad sent a form to you guys, and we got some questions about what you guys are struggling with. So we tried to focus on the ones that you guys are struggling with as much as we can. And at the end, again, if there's something that you guys are not understanding, we can go over it again.
Why do you stop sharing?
Stop sharing. Okay, I'm not the host anymore.
Yes, now you're the host. Try it again.
Can you try now, Rasoul?
Yes. Okay.
Perfect. Okay. All right, we're just gonna go into it. Again, if you guys have any questions, let us know. And yeah, you can stop us at any point you want. Okay.
Okay.
So first of all,
so we're gonna do this lecture by lecture. So that's like, once we're done with it, if you guys have any questions about that lecture, you can stop us and you can explain it. So question number 1, which is the anatomical terminology lecture. When we're talking about your elbow compared to your wrist, which of the following is correct? Is your wrist more distal than your elbow? Is your elbow more distal than your wrist? Is your elbow more deep than your wrist? Or is your elbow more superficial than your wrist? Answer in the chat.
A.
Yes, that's correct. A. Because when something is more distal, that means it's further away from your, like, the origin it's at. So when you're talking about the wrist, the elbow, and the hand, we're talking about the origin, which is at the shoulder. So your wrist is further away from your elbow, from your shoulder, than your elbow. Yes. So B is wrong because it's the opposite. And when you're talking about deep and superficial, it's the layers. So yeah, do you guys have any questions about this?
No, this is clear.
Those are the general terms. Like, superior is what's towards your head, inferior is what's towards your, like, feet, ventral or anterior, which is something that's in the front, dorsal or posterior is something that's close towards the back, medial is something closer to your midline, lateral is away from the midline, intermediate is between those 2 points. Proximal and distal, I just explained them, which is like closer to the origin of something or further away. So when you're talking about proximal, it's closer to the origin of something, so origin of the joint, and then distal, it's further from the joint, and superficial and deep, I explained them as well.
I have a question, just to make sure. Proximal and distal, are they only used for joints?
No. But like, it's relation to the, like, into your, like, closer to the center of your body. So when you're talking about, for example, your foot and your knee, or for example, when you're talking about a neuron, for example, to the cell body of the neuron, or towards or away in the axon. If it's closer to the cell body, it's proximal. If it's further away, it's distal. It's just compared to the origin point. But for the example I had, which was your elbow and your wrist, the origin point was the shoulder joint.
Okay, tamam, shukran.
So usually the origin is close to the midline. So the midline, whatever is proximal to it, that's closer. Whatever is distal is distal. It could be anything.
Okay. So the second question says, a person was stabbed and the knife punctured their spleen. Which of the following cavities was affected? So you're all saying C. And yes, that is correct. Let's see. We'll talk about the cavities really quick. You have first of all, their cavities are divided into 2 parts. You have the dorsal, or the one in the back, and then the ventral, or the one in the front. The dorsal is further subdivided into your cranial, and then your spinal or vertebral. Your cranial has your brain, your vertebral has your spinal cord, and then the ventral cavities are the ones that are closer towards the front of your body. You have the abdominal pelvic, and then you have the thoracic. The thoracic is the one that contains your heart, your lungs, etc. And then your abdominal pelvic is the one that has your stomach, your spleen, stuff like that. Any questions for this? Okay.
No, that's clear.
And then we go to question 3. Which of the following planes divide your body into the superior and inferior sections?
The transverse.
Yes, it is the transverse. Okay, what does the sagittal divide your body into?
Left and right.
Yes, exactly. So you have those 4 types of sections. You have the sagittal, which divides it into left and right. Mid-sagittal, which is the same as the sagittal, but the only difference is that it divides it into equal halves, left and right. Frontal or coronal divide your body into the anterior or front and posterior, the back. And then finally, the transverse divides it into superior and inferior. So it's like cross sections. And
So
that,
So
all their CTs and all the CTs they have is
yes,
usually
so the
transverse.
CT scan, like the one shown here, is a transverse section. But for example, this one, yeah, 1 second. This one is a frontal or a coronal section, because you can see here, you can see the shoulders, you can see the lungs and stuff. Okay.
the only difference between sagittal and mid-sagittal is that sagittal could be in any like point
Yes,
from
so
up to
if
down.
yes, so if it's a section here, it's a sagittal section, but it's not a mid-sagittal. So it divides your body into left and right sections, but they're not equal. But the mid-sagittal divides it into equal parts, left and right. So this is the last question from this lecture. Do you guys have any other questions or anything in that lecture that you don't understand? The anatomical positions or terminology.
It might be helpful for you guys to like open the lectures as we go on.
Yes.
So you can see if there's any concept that you probably don't understand or whatever that we can go over with you guys right now too. So like if we're just gonna move on to the circulatory system. Okay, so first question goes, which of the following vessels is the most oxygenated?
See,
Okay, so
see.
okay, C. Yes, okay. So before I go into the questions, I wanna tell you guys about something that I found really helpful in my first year when I was starting to do write exams here. The way I do the questions is I usually go out and look at the answers first. So I look at the answers and I kind of see what lecture they're trying to talk about or what like concepts they're trying to like assess. And then after that, then I would have like a pretty narrow idea of what they're asking. Then I would go over to the question. For example, if it's a clinical question, then I would go and read the last sentence, see what they're asking, and then I would go on and read the clinical scenario, the full like 7, 8 lines. And that is really helpful when we talk about moles, for example, because in mole, what we get like 80 to 100 questions, and then some of them are clinical. So I find it really helpful to like really exercise how to do questions, how to go on and start doing questions, because then it'd be helpful and like then it'd be faster for us to solve questions. So for example, here we're talking, if we look at the choices, we're talking about different arteries and different veins, for example. So here we know they're trying to assess our knowledge about arteries and veins. They're asking us about most oxygenated, and then you guys said C correctly, which is C. So first of all, what's pulmonary artery? What does the pulmonary artery do? Why is it wrong here?
Pulmonary artery takes the blood away from the heart to the lungs.
Exactly. So the pulmonary artery takes the deoxygenated blood from the heart to the lungs for it to get oxygenated and then comes back. So pulmonary artery is definitely right away. This is wrong. This is deoxygenated. Hepatic portal vein, what does it do?
I think it was from the liver. It was from the liver.
It takes
Sorry?
I think it's like something to do with the liver. I think.
Yes. Okay, yeah. So again, so what do veins do generally? veins bring blood to the heart generally, right? Except for there's one exception when we're talking about pulmonary arteries and veins. But generally, veins bring blood to the heart. So when we're talking about bringing blood to the heart, that means we're bringing blood that's deoxygenated. We're bringing it from around the body to the heart. That means we're taking all the deoxygenated blood to the heart. So when this is easy, then if you guys forget what hepatic portal vein means, in the exam, it's a vein. So most likely, or like 100%, if it's not a pulmonary vein, it's a vein that brings back the oxygenated blood. So that one is wrong for sure. But a hepatic portal vein, again, so you were right about the liver. So it brings the blood from the liver, the deoxygenated blood from the liver, and takes it back to the inferior vena cava, and then it goes back to the heart. Okay, so inferior vena cava, what does it do?
It also carries the oxygenated blood.
Yeah, so inferior vena cava and the superior vena cava, they take the blood, the oxygenated blood from around the
To
body
the right atrium.
to the right atriums. Yeah, so it takes the oxygenated blood. So it's 100% wrong. And then pulmonary vein, again, it's the only vein in the body that carries oxygenated blood, because it will take the oxygenated blood from the lungs. It does bring it back to the heart, but it brings back to the heart oxygenated blood from the lungs. So this is the most oxygenated vessel. And then this is here the explanation. Again, so this is the hepatic portal vein that we're talking about, like right here. It would take it back to the inferior vena cava, and then it would take it back to the heart. Okay, question 5. Which structure collects the lymph from the right upper limb, right side of the head, neck, and thorax, and drains it into the venous circulation?
Thoracic. Or no, hold on.
So we're taking right upper arm, right upper limb.
Yeah, right.
It's A.
Yes.
Yeah, so A is correct. So again, we're looking at the lymph nodes here. So we know we have to focus on lymphs. They're asking us what gets collected from the right upper limb, right side of the head, and the thorax. And this is a straight recall question. But if we look right here, there is one side of the body, which is the right side over here. So all the vessels here, all of them drain into their respective lymph nodes, these 3 lymph nodes. And then after that, they go on to go into the right lymphatic duct. So when we're talking about the left side, which is basically basically everything. So the right.
Let's see.
Yeah. So I'll go over why not see. So for the left side, it's all the body. For the right side, it's only that part. So it's literally half of your the right half of your head, and then your right arm, and a bit of your abdomen. But under that, it's all of it goes into the thoracic duct. So the thoracic duct, we said it drains left side. So right away we know this is not the right answer, because it drains from the left side. And here we're talking about the right upper arm. When we talk about deep cervical lymph, again, deep cervical the deep cervical lymph here could be correct. First of all, it doesn't say if it's right, so we know this is not the most correct answer. And if we're talking about where is it? Sorry. Yeah, when we're talking about the right axillary duct, so here it says right upper arm, right side of the head, and thorax. So all of it.
Yeah.
So all of it in total, all of it drains into the right lymphatic duct at the end. By the end, all of it drains into the right lymphatic duct. So that's the more correct answer. So the right axillary could be right if we're talking about the upper arm, but when we're talking about the right side of the neck, basically the whole right side, all of it drains ultimately at the end into the right lymphatic duct. So that's the more correct answer.
So yeah, like in general, when they're talking about lymph nodes and limbs and drainage, if it's something within this area, which is your right side of your face, the right upper body, and then your right arm, it usually drains into the right lymphatic duct, but everything else drains into the thoracic duct. So yes, they drain into their respective lymph nodes, like the right deep cervical, right axillary, and stuff like that. But eventually, all those lymph nodes drain into either two of the ducts, either the right lymphatic duct or the thoracic duct. So that's when you need to know which part of the body you're talking about. So if they're talking about the right upper limb, right side of the head, like they're talking about here, then yes, it's the right lymphatic duct. But for example, if it was the left arm, the left head, stuff like that, then it would be the thoracic duct.
Does that make sense?
I have a question.
Yes.
So, is there such thing called right axillary duct?
No.
It's a right. It should be right axillary, like lymph node, but it's
Yeah.
there. It's to like to mix you up, guys, up, because they would do that
Yeah.
sometimes exams to like make you like overthink stuff.
Aye, thanks.
Because this is a straight recall question. Right lymph, like when you see right lymphatic duct, you should know this is this is the one that drains all of them ultimately on the right side. So this is the one that's right. So like what we learned in high school, I feel like, is when we see something that we don't know, we're like, oh wait, did we like not study? Did I not go over it or something? But this, like, if you've studied something and you know something, you should have confidence in choosing that answer. Like most of the time, they would put questions to trick you. It'd be like, so you can doubt yourself, basically. And that is one of those options. C. Any questions? All right. So this is one of those clinical questions I was talking about. So first of all, let's look at the options. We're talking about stroke, peripheral artery disease, angina pectoris, and myocardial infarction. So here we're talking about something that has to do with the vascular system, with the circulatory system. Okay. Then let's read the last question here. What condition did this atherosclerosis cause in this patient? Okay, so what's atherosclerosis? You guys know?
Blockage of the arteries.
Yeah, so
By
it's
the
basically
click.
so it's yeah, so it's basically fat deposits in your arteries that make it's basically cholesterol buildup in your arteries that makes blood not able to flow as good as would flow without, like, it's just straight blood flow. So basically just something that kind of messes up the flow, blood flow in your arteries. Okay, so we already know this. That's good. Now we can read the question. So because this question, we can't really answer this question without reading the whole clinical scenario. So let's read it. A 33-year-old man with a history of diabetes mellitus comes to the ER with his family complaining of leg pain while walking. So this is important. He says he works as a cashier for a big company and he spends most of his day standing at the till and dealing with moody customers. He is obese and on examination he seems to have high blood glucose. His sister is worried because his dad has passed away from a health condition. He seems to have developed atherosclerosis, one of his arteries. What does this condition cause in this patient? What do you guys think?
You're saying B.
B?
Yes.
Yes, and B is correct. So again, this whole question, the only important thing here to know is that he has leg pain while walking. That is the only thing so I tried to write this question and tried to make it as long as possible, just to show you that those clinical scenarios, they just like try to trick you basically. All you need to know is that little trick, that like hint right here, leg pain while walking. So peripheral artery disease is correct. Why is it not stroke?
Maybe we can.
Yes, they're right.
Yeah. So stroke affects the brain. I think Dr. Vlad had an example in his lecture saying stroke causes syncope or you guys know what syncope means?
Is it when like half the face is paralyzed?
No, syncope means
Loss of consciousness.
yeah, it's just loss of consciousness. So they just basically pass out. So I think this is what he had in his lecture. So if they said anything that has to do with the brain, just such as loss of consciousness, paralysis, anything like this, then it could have been heart. Not heart, but brain. Has to do with the brain. Angina pectoris. What does angina pectoris mean?
Chest pain?
Yes.
Yeah, it's just chest pain. And then MI or myocardial infarction.
Heart attack?
Artifact, basically, yeah. So here, this is the lecture, this is the slide from Vlad here, from Dr. Vlad. He said, with stroke, it's just difficulty speaking. So anything that's related, brain related, anything that's brain related, they could ask about this. For peripheral artery disease, it's literally all we need to know is leg pain while walking, and that's peripheral artery disease. Again, this is these slides that Dr. Vlad has usually are very important. In our neuro exam, was it in our Dr. Vlad, he taught us
He taught us in neuro and
in neuro. In his neuro lectures, all those slides that he has, like this little ambulance there with a disease, he basically brings questions from. So it's really, really important to know those three scenarios he has, because I think he will bring one of them for sure. So it's either angina pectoris, stroke, and peripheral artery disease. So you guys need to know how to differentiate between them. And then you guys were right with this one. Peripheral artery disease causes, so basically sclerosis in the arteries basically means there's little buildup of fat in your arteries. That means the blood is not reaching the legs as much. So then we would have pain, or we'd have ischemia, or we'd have loss of oxygen to the arteries, or yeah. So we basically would have pain while walking.
Okay.
Do you guys have any questions about this lecture? This is the circularity lecture. So like your cardiac and your venous drainage, yeah.
Because we're moving on to the next lecture.
Moving on to the next lecture.
All good? Okay.
Yes.
So the next lecture is the general anatomy of the musculoskeletal system. So the first question is, Ahmed was playing football with his friends. He fell and fractured his third metacarpal. The metacarpal is which of the following bones? The flat bone, irregular bone, sesamoid bone, or a long bone? What do you guys think?
Long.
Yes, exactly. So a metacarpal is a long bone, and then you have the other types of bones. The flat bone is basically flat bones that are flat. Those include, for example, your skull, like the cranial bones. Those include the sternum, stuff like that. Irregular bones are just bones that cannot be classified as other types of bones. So you have your vertebra and stuff like that. Your sesamoid bones are types of bones that grow in tendons. So you have the patella or your kneecap. And this is the slide that shows the long bones. So you have the humerus, femur, radius ulna, metacarpals, metatarsals, and stuff like that. Any questions? Okay,
Clear.
clear.
Do you have to know every bone?
Do you have to know every bone? I think you need to know the ones that are in the slides. So here they mentioned the humerus, femur, ulna, radius, and stuff like that. So I think they might ask you, like, they might do the same thing that I just did here, where they name a bone and say which of the following is it.
In
If they
irregular
mention-
bone? Yeah, in irregular bones.
Irregular bones, let me check the slides.
For irregular,
I think they mentioned the vertebra.
I mean, it's easy when you're memorizing the other types of bones. So like, for example, if you already know the long bones, sesamoid bones, and then
Okay.
your other examples, then you can differentiate, be like, okay, this is not one of those three, so it must be a irregular
So
bone.
in your slides, they mentioned for irregular bones, they mentioned. Oh, okay.
Yeah.
So they mentioned the facial bones and the vertebra. I don't think they're gonna ask you for like specific facial bones, because I think that's like way too detailed to take that the MSK stuff in second years. But just when they get you a bone, just think if you know it or not. If it's a long bone, if it's a long bone, if it's stuff like that, then yeah. Because a maxilla, for example, is a bone in your face. So you would know that it's not a flat bone, it's not stuff like that. So you know it's an irregular bone. So
Yeah, one of the easiest things, like for me, was that if I don't want to memorize one of the things, I memorize everything
Yeah.
else. Like like I know it's not a long bone, it's not a sesamoid bone, it's not
Yeah.
like a flat bone. Then it must be the fourth, which is the irregular bone.
Yeah, and usually any bone that like you don't know the name of, which is like maxilla, ethmoid bone, stuff like that, they're usually the irregular bones. But bones like, for example, your femur, your humerus, your carpals, which are your wrist, your tarsals, which are your ankle bones, those are the bones that you know. So they would be like short bones, stuff like that. But the irregular bones are usually like the weird bones around your body. So your facial bones, you have your hyoid bone here, you have your vertebra, stuff like that. So I think know them, like read through them, try to memorize them as much as you can, because yes, they might ask you a question for them, but you can also do the thing where you memorize all the easy stuff, and then the ones that are not there are the regular ones. All good?
Yep.
Okay. So the next question is, the epiphyseal disc is located in which
C.
of the following in the long bones? So what did you say?
C.
Let me read the question, man.
Metaphysis.
Yeah, like give it like a couple of seconds until you
Yeah.
answer. So, what do you guys think? First of all, like when you get a question like this and you're not sure, read what they're asking about. The epiphyseal disc. Do you guys know what the epiphyseal disc is?
It's like when the cartilage hardens, right?
Yeah, it is the cartilage that is found in your long bones. So it's the cartilage that's between the head of the long bone and the body of the long bone. It's what causes you to like grow. It's the point that causes new bone formation when you're young to be able to grow. So this disc is located between those two parts. So what is the area between those two parts? What is it called? So the top part is called the epiphysis. So you have the distal. Remember when I was saying distal is further away from the joint? Yes. So you have the diaphysis, which is the shaft or the middle part, large part, the epiphysis, which is the ends. So the part in between is the metaphysis. So they're asking about something in between those two parts. So it's the metaphysis. So it is C. And as you can see here, this is what I was talking about. You have the ends, which are the epiphysis. You have the shaft, which is the diaphysis. And here you can see the epiphyseal line or the epiphyseal disc. When someone is young, it's called the epiphyseal disc because it's still cartilage. But when they grow up, this cartilage becomes a bone, and it's called the epiphyseal line. So this is the case between the two parts, the proximal epiphysis or the distal epiphysis and the diaphysis, or which is called the metaphysis. So the point in between those two parts is called the metaphysis, and the epiphyseal disc or the epiphyseal line is located in this metaphysis. It's kind of a recall question, but like it's good to understand what it is so you can get it during the exam. All good? Okay. And then you have this question. So the proximal radio ulnar joint is an example of which of the following joints?
Five.
So you guys are saying C, a pivot joint. Do you all agree? Okay, yes, you're right. It is a pivot joint. So what is the radio ulnar joint? It's basically, you guys know what your radius and your ulna are. There are two bones that are located in your forearm here. So the radius is the one next to your thumb or the lateral one, and the ulna is the one next to your pinky or the medial one. So you know that you can do this with your hand, which is supination and pronation. So this movement is facilitated by this joint, the radio ulnar joint. So it's basically like do you guys know what the pivot is? It's basically like something that is wrapped around another thing and it turns around. So a hinge joint, let's like eliminate the other things so you guys can get it. The hinge joint, a hinge is like a door hinge. So it's something that it's like the door. So a hinge joint is like your elbow, like your knee, stuff like that. And then the saddle joint, and the saddle joint is like it's you guys know like a horse saddle. It's like an egg shape and then another thing that fits over the egg shape. This is located in your wrist, like bones in your wrist. And then you have the ball and socket joint, which is literally a ball that fits into a socket. This is an example of your shoulder joint and your hip joint. And then finally, you have the pivot joint, which is this type of joint. As I said, you have your radius and then your ulna. It's like a tube that fits into a circle that allows it to like turn like a screwdriver, or like in a single plane, 180 degrees like this. So it's called a pivot joint. Any question? All clear? Any question about any other joints, any other thing in the MSK lecture? What was the answer for question 8? Question 8 was the metaphysis. So the point between the diaphysis and the epiphysis. Yes. No problem. Any question about the musculoskeletal lecture? Okay, we have one more question. What is the muscle that provides the major force for movement? I'll get back to your question, like what the classification is done. So what do you guys think? Do you think the answer is for this one? People are saying A, prime movers. People are saying C, synergists. People are saying D, antagonists.
C.
People are, so every single answer has been answered. Okay, let's like delve deeper into the question. We're asking about a muscle that provides the major force to produce a specific movement. So it's the major thing, it's the prime thing that causes this movement. So it's the prime mover. So it's the main muscle that causes this movement. I'll talk about others, like the other ones. So you have the prime mover, which does the main thing. You have the fixator. What is a fixator? It's basically there's a muscle, for example, the prime mover, it does a main movement. For example, let's say it's the flexion of the elbow. A fixator is like an accessory muscle that helps like keep this movement fixed or stable. So it's not doing the main movement, it's just making sure that that joint is stable. An example for this is you're gonna take this later on in your MSK block, but you have muscles here called the rotator cuff. They stabilize your shoulder joint while some muscles move it. So fixators are basically stabilize the joint while other muscles move it so that your joint doesn't fly around. The third,
So the fixator helps in the movement. It's not the major force.
yes.
Yeah.
And then you have the synergists, which are basically two muscles that work together to do a specific function. So I wrote them here. So the prime mover is the first one that does the main specific movement. The fixator is like a group of muscles that stabilize the joint, as I said. So there's one main mover or the prime mover that does the movement, and then you have extra accessory muscles that are next to that the joint that stabilize that joint, so it doesn't move around freely. And then you have the synergists, which act together to do the movement. For example, you have two muscles here. You have the biceps brachii, which is the one that does the flexion, but you also have another muscle known as the brachioradialis. This one right here, that also does the exact same movement, but it helps the biceps. So both of them are working together to do the same movement. So it's like two prime movers, but not really. Don't think about it as a prime mover. Like a prime mover is a muscle that does the function all on its own. The synergists are two that work together, or more than one that work together, like to do a specific function.
Think of it as Batman and Robin, basically.
Yes. So like
Batman is the prime mover, Robin is just helps.
Yes.
Yeah.
And then you have antagonists, which are opposite to each other. So you, for example, you have your biceps and your triceps. They do opposite movements. Your biceps flex your elbow, the triceps extend your elbow. So they do opposite actions. So this is why when they're asking about the major force or the main force, it's the prime movement, which is A. All clear? All good? Yes, no? Okay.
Yes, clear.
Okay, that's it for the MSK question, the lecture. Do you have any questions? There's a lot of classifications of trapezius and things. That do we need to know them because we have a very long name like semimembranous and semitendinous. What do you mean? Where are they in the lecture? Let me see. What slide are you talking about? If you're talking about the classification of the direction of fibers and stuff, then try to remember one from every example. So for example, wait, let me share the screen here. Can I share the screen? Or can I not share it? Can I share the screen?
Yours?
Yeah.
Try.
Okay. Okay, so for example, in the classification of skeletal muscles based on like the fascicle arrangement. Here they like each muscle is classified. You know what fascicles are? Fascicles are basically groups of muscle fibers that are bundled together to make the whole muscle. So muscles are
I
classified.
slide under them.
Yeah. I'll get to that. So every muscle is classified based on that thing, the arrangement of fibers. So what I would say you guys should do is memorize a what's it called? A type of like an example of a muscle for each one. Because just in case they get you in the exam, like obliques, or is an example of which of the following arrangement, you guys can know them. So circular, stuff like that. And then for shape, you have stuff like the trapezius or serratus anterior. Trapezius is this muscle right here, the one in your back. It looks like a trapezoid. That's why its name is based on its shape. So a trapezius. And then you have the serratus anterior. Serratus is another name for like so you know what the saw that you cut wood with? That like the edge of it is called serrated edge. So the serratus anterior is basically a muscle that looks like the serrations of that saw. And then you have by number of heads, which is biceps, triceps. Biceps has 2 heads, triceps has 3 heads. And then for gross structure here, it's basically a like the naming of the muscle of a muscle based on its structure. So semitendinous is semitendinosus looks like a tendon, so it's called semitendinosus. Semimembranosus looks like a membrane, so it's called semimembranosus. And then they're also named by the location. So for example, supraspinatus, you have your scapula. There's a spine on your scapula. When there's a muscle above that spine, it's called supraspinatus. And then you have the temporalis. This part on your head is called your temple. So the muscle that's here is called temporalis. So it's basically just telling you guys how like they're named based on stuff like that. There's also attachments. There's a coracobrachialis. It's between the coracoid process of the scapula and stuff like that. I don't think you really need to know why they're named like that. It's maybe just like coracobrachialis is named based on its attachment and stuff like that. I don't think they're gonna ask you this much details because that's more MSK, right? Yeah, like because stuff like that is much more MSK than foundation. But read through them, try to understand why they're called like that, just in case they get them in the exam. But I don't think they're gonna get stuff like that.
And this is also good to know because yeah, again, this is basic, so you guys will need to know this like in the future in MSK or whatever. So I think it's important to know how like these muscles are named and stuff.
And like once you like try to understand why they're named like this, it's pretty simple. So for example, rectus femoris, rectus means straight, rectus abdominis, sorry. Rectus means straight. That means the fibers are straight, and abdominis means it's in the abdomen. So rectus abdominis, straight abdomen. Or transversus abdominis, it's transverse across the abdomen. And then depending on the size, you have the gluteus maximus, medius, and minimus. Maximus has the largest size of fibers, medius, and stuff like that. So yeah, I think they're not gonna ask you like difficult ones, but it's good. So like it's good to know, and it's like if you understand why the name like this, it's pretty simple. All good? Okay. Can you share again?
Perfect. Okay, now we're gonna go to everyone's favorite lecture. We heard a lot of feedback about this lecture, so I decided to personally write interesting question. Let's say it like that. So this is the autonomic nervous system. A 27-year-old woman comes to the ER with anhidrosis, ptosis, and meiosis. First of all, do you guys know what
Horner
anhidrosis?
syndrome.
Perfect. Okay, yes. So when you guys hear those three names, it's Horner syndrome right away. But what does anhidrosis mean? You guys know what anhidrosis means?
Is it not being able to sweat through the skin?
But yeah,
Yes.
so perfect. It's hydro, yeah. So like it has to do with water, has to do with liquid, and you can't. So yeah, you can't sweat. Ptosis. What does ptosis mean? Yeah, ptosis, eye droop.
Like the eyelid, it swells inwards, something like that.
Yeah, so basically the eyelid droops. So yeah, your eyelid just comes down. Again, ptosis starts with a P, droop has the P, ptosis, eye droop. Okay. And then meiosis, what does meiosis mean?
Like the pupil, it's like constricts, something like that.
Yes. Constriction of the pupils. Okay. Let's go. Let's what is when do we get meiosis, for example? Let's ask that. Like would we get this when we're in a fight, or would we get this when we're resting? The constriction.
I think when there's excess of light, so I think something like fight situation.
Yeah, excessive light. Yeah. But does it happen when we're in a fight or flight situation, or does it happen when we're resting and digesting?
I think fight or flight situation.
Fight or flight.
What
Meiosis.
meiosis?
Yeah.
So constriction or dilation?
Constriction.
No, constriction
So,
is
yeah,
no
constriction-
constriction is in resting.
Yeah, constriction is in resting. So
If you guys understand why it happens, then you'll like think about why what would you
So,
need. So
yes.
if you're fighting something or you're running away from something, you would want more light to come into your eyes so you can see better. So you want it to be dilated. But if, for example, if you're resting, you want to sleep, stuff like that, you need it to be constricted so that less light will go into it. You can rest.
yeah, and again, one of you guys said Horner syndrome. What does Horner syndrome mean?
The breakdown of one of the gilias.
Sorry?
One gilias is damaged.
What is damaged?
One of the gilias.
The the ganglions or the glias? What are you saying? I don't understand.
The neurogilias.
Neuroglias, yeah, neuroglia. Yeah. Okay, sure, yeah. So what Horner syndrome, what causes Horner syndrome is basically loss or damage to sympathetic fibers. Okay, that is like the simplest way you can put it. And what causes Horner syndrome is loss to sympathetic. What does sympathetic nervous system do?
What response is it responsible for?
Yeah, what does it help? Does it help us in fight or flight, or does it help us in rest and digest?
Yes, fight or
Fight
flight.
or flight. Perfect. Okay, so up to right now, we know it's Horner syndrome. We know there's something is damaged in the sympathetic pathway. Okay, she got a diagnosis with a disease that causes a lesion in the neural tract that contains neurons with which of the following characteristics. So basically, they're asking us what is the characteristic of sympathetic nervous system, basically. So out of those answers, what do we think is the closest, or what do we think is a characteristic or a feature of the sympathetic nervous system? Okay, I'm seeing E's. Yeah, so E is correct. So E is the right answer here. Okay, let's unfold this here. Let's see why it's E. So first of all, neurons. So those neurons have long preganglionic fibers. So is that correct? What has long preganglionic fibers? Parasympathetic, yeah. So actually no, yeah. So sympathetic nervous system has short preganglionic fibers and long postganglionic fibers. For parasympathetic, it's the opposite. It has long preganglionic fibers and short postganglionic fibers. Okay, when we're talking about ganglionic fibers, what are we talking about here? We're talking about, so it's a tract that's the preganglionic that arrives to a ganglion, and then from that ganglion we get a postganglionic that goes into our different organs or the skin or different different parts of the body. So this is where we talk about postganglionic and preganglionic. So it's a before the ganglion and after the ganglion. Okay, so this one is the parasympathetic feature. So this one is definitely not correct. So this is parasympathetic. Okay, so what's B? Neurons that constrict pupils.
Remember when we said the fight or flight thing? When do we need to constrict the pupils? When we're fighting something or when we're resting?
During rest and mostly preganglionic presympathetic.
So is it parasympathetic or sympathetic?
Para.
parasympathetic, yeah. So again, when we're in a fight or flight situation, our eyes dilate. So it's sympathetic nervous system dilates pupils. So this one is constrict pupils, so this is also parasympathetic. Okay. Now C, neurons that are found in S2, 3, and 4. What characteristic of what characteristic is this? Para again, yeah. So can someone tell me where the sympathetic neurons are found?
Between which
Yeah, in what
layer of the
in
spine?
what area of the vertebra is it found? Perfect. T1 to L2. So again, this is also very important. They might bring it the same question, but put T1 to L2. For T1 and L2, these are sympathetic features. Okay. Now, who can tell me what other than S2, 3, and 4, where else can we find parasympathetic fibers in a vertebrae also? Or in vertebrate brain area?
Was cephalic?
Perfect,
Sorry,
yes.
cervical.
Yeah, so
That's
not cervical, it's cranial. Yeah. So we get them in brain nerves. So the C is for yeah. So brainstem is right, yes. So parasympathetic is present in the cranial nerves and in the sacral area S2, 3, and 4. Other
Is
than
it
that one,
the is it the cranial nerves 3, 7, 9, and 10?
I'm not entirely
yes,
sure.
yes.
Yeah, it's those 4 for sure. I don't know if the other ones are part, but those ones for sure, yes. So they are present in those cranial nerves and then in the sacral area. Now when we're talking about sympathetic is only it's T1 to L2. So we need to know also that sympathetic is in those areas as well. Now neurons that have small ganglia, this one is really low yield, but I honestly just wanted the fifth choice, so I put that one. So small ganglia, again, that's a parasympathetic feature, it's not a sympathetic feature. Okay, now the right answer again is neurons that have postganglionic axons that use norepinephrine as a neurotransmitter. Okay, so we said this one is a sympathetic feature. What do parasympathetic release as their neurotransmitters? Acetylcholine, yes. Is that postganglionic or preganglionic?
It's preganglionic.
It's both. So it's for parasympathetic, it releases acetylcholine in the preganglionic area and the postganglionic area. For sympathetic, it releases acetylcholine in the preganglionic, but norepinephrine in the postganglionic. Does that make sense?
Yes.
So this is the diagram I found in your slides. And again, I think in this question we went over like basically like all the high yield questions that they can ask you about the differences between those two. Okay. Now, a 39-year-old woman returns home after eating at a buffet. An hour later, she is relaxing in front of the television. Which of the following autonomic responses is most likely occurring at this time? Receptors for autonomic, or like A1, B1, like A1 and those ones, right? You mean?
The alpha and beta receptors, you know?
Yeah.
I think it's A.
Oh, in other words, we're talking about
Yeah.
like someone asked a question in the chat asking if we should
I
know
mean
the receptor.
the nicotinic receptors and the adrenergic receptors.
When I went over the lecture, which is right here, actually, let's see. When I went over the lecture, I didn't see anything about receptors.
You can see them in the picture.
Which picture?
The
You know
one,
what slide?
maybe no, I think it's in the physiology part.
Physiology. Okay. For what I remember, I don't think they would bring receptors in foundation. I don't remember them bringing it ever in foundation. They brought it in MSK.
Yes.
When Dr. Al-Jabbar gave us a lecture.
But if it's physiology, they might
Physiology,
ask, yes.
yeah, I'm not sure. I didn't go over those lectures. I think, yeah, Yusuf did the lecture, yes, 2 days ago,
The physiology review.
physiology review. I'm not sure if you went over it.
They might not ask you in details, but it's better to know them, I think. Like which receptor is for parasympathetic and sympathetic stuff. So if it's
You-
adrenergic, it's probably more like
Yeah,
sympathetic.
so yeah, what you need to know from what I think you need to know here is that adrenergic. When we talk about adrenergic, these are sympathetic receptors. We're talking about what else?
Muscarinic.
Muscarinic is acetylcholine, so muscarinic is a parasympathetic. Other than that, I don't think they would go in detail and ask you about different like alpha 1, beta 1. Like I honestly still don't even understand them fully, to be honest. Like
Yeah, like they'll ask you, like, for example, maybe the muscarinic stuff, the adrenergic stuff, maybe, but I don't think they're gonna ask you if B2 receptor is activated or what's gonna
Mhm.
happen.
yeah, unless there's a lecture on it in physio. I didn't go over physio, to be honest. Okay. So yeah, back to our question. You guys said A.
So
Okay.
I think it's A because like she had food and then like peristalsis is I think digestion related. So
Yeah, perfect. Okay. So what we need to know from this question is that she is relaxing. So right away, this is a hint telling us that she's basically in a rest and digest situation. So what happens when we're resting and digesting? First of all, what happens to our eyes, we said?
Do they constrict?
contraction of the pupils.
Contraction, yes. So yeah,
Yes.
constriction of the eyelids. Would we, if we're just sitting relaxing, what I used to when I studied foundation, I think I used to whenever I thought of parasympathetic or rest and digest, I imagine myself on the beach. So like, what would happen if I'm on the beach? Like, would if I'm just sitting and relaxing, would I be sweating? I mean, I would be sweating if it was hot, but like, would I be sweating if I was just sitting in a cozy, comfy area? Probably not, right? So I would be sweating if I was in a fight or flight kind of situation. So if I'm relaxing, resting, digesting, I won't be sweating. So this one is wrong. Would I have circulating epinephrine?
I don't think so because you're not in a fight or flight. Fight or flight situation.
Perfect.
Yes.
Yeah. So that's fight or flight. That's when sympathetic is activated. I'm resting now. Parasympathetic is activated. So we have acetylcholine. We don't have epinephrine. If this was acetylcholine, then that would be the right answer, like with the peristalsis. But this is epinephrine. Okay. Now we're talking about decreased blood flow to the skin.
I think it's not the option because it's not an autonomic related something like that.
It's not the option, you're right, but the reason why you would have decreased blood flow in the the fight or flight response or the sympathetic response is because your body would need blood at other places. For example, you'd need blood in your muscles, you need blood because you're running and stuff like that. So it automatically decrease the blood flow from your skin so it can go and be redirected to other places. But if you're resting, you wouldn't need to do that. So you wouldn't have a decrease in blood flow.
Yeah. Okay. Now, dilation of bronchioles.
Yes, epinephrine is related to the adrenal gland. But at the same time, it's also
That is a very good point. Yeah. So the adrenal gland is the only organ that is directly innervated by the sympathetic system.
Yes.
So yeah, so that is a different way of thinking about it, but that is yeah, you're right. So again, a dilation of the bronchioles happens in what's it called in sympathetic. It doesn't happen in parasympathetic. Again, because if we're dilating the bronchioles, that means we're breathing
more.
we're breathing heavy. Yeah. So when we're in a fight or flight, then we need to be breathing heavy. But if we are relaxing, we don't need dilatation of the bronchioles. Like we need more air in there.
Again, it's the same reason as the decreased blood flow. Because when you're running, when you're using your muscles and stuff, you would need more oxygen. So your bronchioles or your lungs will automatically dilate so you can get more oxygen in so that you can use that oxygen.
Yeah. Does that make sense?
Rasoul, how are you in the beach when there's a FND exam coming up?
See, yeah, I like I like to I like to think of things that make me happy, when I'm studying. So it's a good way to think about it. It takes my mind off studying for a little bit.
It makes sense.
This is the wrong example to bring right here because they were talking about sweating. So like that wouldn't
Yeah,
really work.
let's say you're sitting
Let's say
down
we're sitting watching television.
or
Let's say that.
studying fun.
Yeah. That is when you're resting and digesting.
I have a question.
Yeah.
We said that in sympathetic, we use non-epinephrine, and also in parasympathetic, we use non-epinephrine. So when do we use epinephrine?
No, so in parasympathetic, we strictly use acetylcholine only. We don't use norepinephrine or epinephrine in parasympathetic. In sympathetic, we use epinephrine or norepinephrine because they're the same. So norepinephrine is just basically a precursor of epinephrine. So they're the same thing. We use them in postganglionic fibers only. Does that make sense? In parasympathetic, it's strictly acetylcholine.
Yes, but we said like in post-ganglionic axon, in parasympathetic, we will use non-epinephrine.
No. In
No.
for parasympathetic, it's strictly acetylcholine. You
Yeah.
can see it here. You can see here in the table it says the neurotransmitters.
I think you were talking about in preganglionic, we use acetylcholine.
Yes.
So in sympathetic nervous system, the only similarity we have in the sympathetic and the parasympathetic is that in preganglionic, for both we use acetylcholine. Okay. But norepinephrine is only used in sympathetic, only in postganglionic fibers.
Yes. Okay, thank you.
Of course. Okay. We have one more question. Yeah.
I think so.
Okay, so this one is a recall question. Which spinal cord level contains the entire population of preganglionic sympathetic neurons? I think we already answered this.
Yeah.
Yeah.
Someone answered this in
We
the
already
class,
answered this.
but try answering it.
D.
Yeah.
Yes, you're right.
So this one's strictly recall. We've already talked about parasympathetic. Again, parasympathetic is sacral and cranial nerves. So when they bring up cranial nerves, specifically in this exam foundation, when we bring up cranial nerves, they're talking about parasympathetic. Again here. So for something about these, I feel like a lot of people are like having problems with like understanding these. If you think about it in terms of fight or flight, rest and digest, then it would make sense to you. Like, like it would make sense why you would have salivation when you're like sitting, when you're resting and digesting. It would make sense why your heart level slows down. Makes sense why you would need to you need to go to the washroom. So it would just, you try to think about it in rest and digest and fight or flight, then it's all gonna make sense. And then again, rest and digest is parasympathetic, fight or flight is sympathetic. Do you guys have any questions about this lecture?
All good?
I think I wanted to bring up one more thing, actually, I forgot. For sweat glands, yeah, sweat glands. So sweat glands are the only organ that it gets the innervation from sympathetic and has acetylcholine. Okay, so I think this is a very high yield point, and I think they probably will bring this because sweat gland is still a sympathetic innervated organ. Sorry about that. It's strictly a sympathetic innervated organ, but we get acetylcholine instead of norepinephrine. Okay, this is a very high yield point. I think they might assess you on how many questions are in the exam.
It's a good question.
I think
it's
usually about like
80, yeah,
80,
something like
usually
that.
about 80
80 MCQs
or less. I mean, this is the first time we get foundation and heme, so we don't really.
Yeah, because of that they might go like 80, 90, but I don't think it's more than that.
Yeah, you guys won't be getting a lot.
Could you repeat the point about the sweat?
Okay. So again, we said sympathetic nervous system gets it releases norepinephrine in the postganglionic fibers, except for one condition. When the sweat glands are innervated. So this is the only exception where the sympathetic nervous system secretes acetylcholine instead.
So in every other place in the body, the sympathetic nervous system, the postganglionic fibers will have norepinephrine, but the only place in your body that will have acetylcholine instead as a postganglionic is the sweat glands.
Okay.
All good?
They said 90 to 100. Yeah, we have no idea, honestly. We don't know. Yeah.
Okay. So
Isn't
now
it sweat glands and erectile tissue that uses acetylcholine?
And what, sorry?
erectile tissue.
Erectile tissue?
I don't think so.
I don't, is it in the lecture?
I think I read it in the slides.
And anatomy as well?
It's probably physiology also.
Because I think they were talking about. Yeah, I remember only reading
Because
only reading sweat
yeah,
glands.
I think sweat glands is the only exception. But because I think erectile tissue has a thing where parasympathetic, because it's something that will take later on in endorepro, that they have the parasympathetic is what causes
They
the
have dual,
contraction.
yeah, they have dual innervation, so I think that's why they probably had it.
But
But it's
no,
not the exception.
the only exception of norepinephrine is in the sweat glands. Is that clear? Is everything clear with the autonomic nervous system lecture?
Perfect.
Okay. So I'll get to that point. Someone's asking if I can explain the white and gray rami. I'll explain it when I get to the question in this stuff.
This is
So now this is the general anatomy of the nervous system. So first question is, a person visited the emergency room complaining of loss of vision. Which of the following types of neurons is most likely affected? So when you see this, you see loss of vision, and then you think about it. What loss of vision is a special sensation, and special sensations are innervated by yes, right, the bipolar. So you can see here, you have the bipolar are sensory, but they are for special sensations. So they're like your olfactory or your smell, your retina or your sight, or in your ear or your hearing. Those are by the bipolar cells. You have pseudo-unipolar, which function in sensory. So the way I memorized it is pseudo-unipolar has sounds like an S in the beginning, so it's sensory. Multipolar sounds like an M or muscles, so it's motor. And then the bipolar is the special one. So it's the one that has the special sensation. So the sight, the hearing, stuff like that. And then the last one here, unipolar. Unipolar is something I made up. It's not found in humans, it's found in fish and stuff like that. Is that clear? Okay. The second question is this. A 51-year-old male presented to the emergency room with numbness in his legs. It was revealed after investigation that his peripheral nerves lost their myelin sheath due to an autoimmune disorder. Which of the following cells is most likely affected? Yes, Schwann cells. Because it's Schwann cells because we said it's peripheral nerves. But if we said that it's something in the central nervous system or the CNS, then it would be which answer? Yes, B. So Schwann cells are for myelination of the peripheral nervous system. Oligodendrocytes are for the myelination of the central nervous system. And here is start explaining it. You can see here that this is the axon or the nerve, and all of this is the Schwann cell. And you can see here the layers. The Schwann cell wraps itself around the axon to form the myelin sheath. All clear? For question 15, question 15 is A, because we're talking about peripheral nerves. So if oligodendrocytes is for the PNS, and oligodendrocytes is for CNS. Schwann cells is for PNS, and oligodendrocytes is for CNS. Okay, and then the next question. The cell bodies of the sensory nerves are located in which of the following? What is question 14 again? One second, I'll go back to it. Question 14 is asking you about the classifications of the neurons. So you have three types in humans. You have bipolar, pseudo-unipolar, and multipolar. We said that bipolar is for sensory, for special sensations like your vision, your hearing, your smell. Your pseudo-unipolar, which sounds like an S at the beginning, is for your sensory. And then the multipolar has an M in the beginning, so it's for motor or for movement or for stuff that you control. Good? Okay. So now question 16. Again, the cell bodies of sensory nerves are located in which of the following? You guys are saying B. That is correct. Okay. So do you guys know what the ventral horn is for?
It's a part of the spinal cord.
Yes, and it's with what? Yes, exactly. It's for motor. So, and do you guys know what the lateral horn is for?
Preganglionic sympathetic nerves. Cell
Yes,
bodies.
for sure. And central canal has nothing to, it's just a canal in the middle of the spinal cord that has CSF. So this is the slide that explains it. You have the ventral horn, which is this part here. That is for the preganglion, the motor neurons. And then you have the lateral horn, which is this one right here. That is for the preganglionic sympathetic. And then you have the dorsal root ganglion, which is right here, which is for the sensory neurons. Is that good? Okay. And then someone asked me to explain the white and gray matter. Basically, in your spinal cord right here, you have two types of like tissue. We have the white matter and you have the gray matter. The white matter in your spinal cord is usually on the outside, and then the gray matter is usually on the inside. The reason why it's white and gray is because what's it called? The reason why it's white and gray is because of the myelin sheath, or the wrapping of oligodendrocytes and Schwann cells on the neurons. So that's the difference between white and gray matter.
And then this part also confused me for a bit. When I was studying neuro, the spinal cord is the opposite to the brain.
Yeah. So in your brain, your white matter is on the inside and your gray matter is on the outside. On your spinal cord, the white matter is on the outside and the gray matter is on the inside. The way I memorized it is that in your spinal cord, you have your vertebrae around it. So you have the bone on the outside. The bone is white, so it's on the outside. But in your spinal cord, your brain, there's no like vertebra around it, so the white stuff is on the inside.
It's again, this is also like way too detailed for this is like intro lecture. But yeah.
And then someone was asking to explain GVE, GSC, GVA, and GSA. Yes. Okay, so you have 4 classifications of like the types of like impulses or like nerves itself. You have GSC, GVE, GVA, and GSA. What those mean is that a GSE, let's go one by one. GSE is general somatic efferent. And what that means, let's do like one by one. Efferent means that it's going towards something. So it's probably not sensory, it's probably motor. Okay? And then somatic is basically it's embryologic in origin, so it's from the somites. So those are usually your skeletal muscles. And general means that it's not for a specific like specialized organ like your eye, your ear, stuff like that. So when something is general somatic efferent, that means it's a nerve going towards a somite. So it's a voluntary nerve, or like you're doing an action. And yeah, so
It's like basically your hand moving.
yes, so
Your
a
hand moving
general
is that-
somatic efferent is basically a nerve that's going to a somite, which is your skeletal muscle, stuff like that, for an action, like your motor stuff, moving your hand, moving your muscles. And then you have your general visceral efferent, because it's the same thing, GVE, so general visceral efferent. It's the same thing, but instead of going to somites, which are your skeletal muscle, it's going to viscera. Do you guys know what viscera are? You know what the word viscera means? Okay, a viscera is basically an organ. So a general visceral efferent, that means it's a nerve that's going towards a viscera, but it's general, so it's not a specialized organ. So it's not your eye. It's, for example, it's a nerve going to your, let's say, your intestines for peristalsis. It's going to your stomach for stuff like that. So whenever you see the word efferent or the letter E, that means it's a nerve that's going towards an organ to cause an action. So for general somatic efferent, the word somite should make you think of skeletal muscle and stuff like that. The general visceral efferent should make you think of organs. So what goes to skeletal muscles? It's your motor neurons. What goes to your what's it called? To your organs, like the visceral organs, like your stomach and stuff like that. It's the sympathetic nervous system. And then you have your GSA and GVA. The general somatic afferent and general visceral afferent. When I said efferent, I was talking about something going towards an organ. But when I'm saying afferent, it means something is coming from an organ. So if something is coming from an organ, is it sensory or is it motor? If an impulse is coming from away from your spinal cord and your brain and coming towards it, are you sending a signal or are you receiving a signal? Yes. So when something is 1 second. When something is afferent, that means it's sensory. When something is efferent, that means it's motor. So a general somatic efferent is motor to your muscles. A general visceral efferent is a sympathetic supply to your organs. But in both cases of GVA and GSA, it's afferent, so it's sensory. So whenever you see the letter E, it's talking about something that is sensory, like a motor. So you're giving an action to something. When you see the letter A, it's sensory, so you're receiving sensation from something.
So the way I memorized it was A comes before E. So A is sensory, E is motor. So I sense something is hot, that's an A. Afferent, I would like take my hand, that's an E. Motor.
You'll take this more details later on, but it's good to have a general idea about this. This is all clear? If you have any questions about this, ask me, because it caused a bit of confusion when we were taking it in neuro, but it's pretty simple, actually, understand.
The next question is about eye.
Yeah. So the person that asked me this question answered the question. Okay, so which of the following neurons conducts impulses to skeletal muscles of your body? So it's going towards something. Is it afferent or efferent? Yes, you're right. It's A. So because it's going towards a skeletal muscle, then it should be somatic, and it's sending impulses to it, so it should be efferent. So it's general somatic efferent. Clear? Good? Okay. So this is the same slide explaining it. So GSE, or the motor neurons or skeletal muscles, is this. And then the next question for the neuro is this. The sternocleidomastoid is controlled by which of the following muscles? Do you guys know what the sternocleidomastoid is? Yes, you're right. It's D. Okay. No, sternocleidomastoid is basically, there's a muscle here in your neck that's responsible for turning your face to the right and left. And this muscle is supplied by the accessory nerve, as you said. So why is it not the facial nerve? What does the facial nerve do? It's from the name. Yes. You're right.
Yeah, so
Facial.
motor.
It's a motor nerve that controls your facial expression, so the muscles of your face. And then what does the trigeminal nerve do? Yes, you're right. So trigeminal nerve has 2 functions. It has the sensation of the face, so it's a sensory for the face, and it also supplies the muscles for chewing. And then what does the abducens nerve do? The name should give you a kind of hint to it. Yes, so the abducens nerve supplies an eye muscle that causes the abduction, or moving your eye away from the center. So this is a list of all the cranial nerves and their function. So you have the first nerve, cranial nerve 1, which is an olfactory nerve, which is for your smell. You have the second nerve, or cranial nerve 2, which is your optic nerve, which helps you see. You have cranial nerve 3, 4, and 5. Those are responsible for the muscles of the eye, for the movement of the eye. And then you have cranial nerve 5, or the trigeminal, as we said, it's for the sensation of the skin of the face, as well as chewing. Then you have cranial nerve 7. They flipped 5 and 6. They have cranial nerve 7, which is the facial nerve, which is, again, as you said, for muscles of your face. Then vestibular is for your ear. The glossopharyngeal is, yeah. I don't think you're supposed to know them in this much detail, but it's like good to know which, like, if just know a general idea of each one of them. The glossopharyngeal nerve is it controls a gland which is here. It's called the parotid gland. I don't think you need to know it in much detail.
They said with
They said with details.
I mean, again, because Dr.
Like simple functions, like muscles of the eyes, sense of smell,
Sure.
simple functions, the ones with the brackets, or yes.
Okay, stuff like,
So
like simple
everything
function.
here.
I think simple function, sure, like smell and stuff like that. But like, I don't know, because knowing what it does to the parotid gland, I think is a bit too advanced for you guys.
Facial nerve, for example, facial nerve, trigeminal nerve, accessory nerve, vagus nerve, yes. But I think we're talking about 8 and 9.
Like 8 and 9, their function is way too detailed. I don't think you guys need to know them in this much. Maybe just know that they're related to your hearing and balance, because vestibulo is for your hearing, and then sorry, vestibular is for balance, and cochlear is for your hearing. I don't think you need to know them in much detail, but it's okay. It's a good thing to know. So vestibular is for balance, and cochlear is for hearing. Glossopharyngeal, it's for your parotid gland and your sensation from the posterior 1/3 of the tongue. The vagus is your it controls the swallowing, regulation of heart rate and breathing. It's a main nerve for the parasympathetic nervous system. You have the accessory nerve, which is the one we talked about here. It's to control your sternocleidomastoid, which is a muscle that's here, and the trapezius. And then finally, cranial nerve 12, which is hypoglossal, which is for your tongue. I would say memorize them, but like don't like memorize what's on the slide here. Don't go into details of like looking them up and stuff like that to know what they do, because they're way too complicated for your stage right now. Just know what's on the slide right now, just in case they ask you what. But I don't think they're gonna ask you in so much details. Like they might ask you the same way I asked here, like which of the following is for the sternocleidomastoid. Is that good? Clear? Okay. And question 19. Which of the following impinges on spinal roots in the vertebral disc herniation? Impinges means it pushes on the vertebral roots. Someone said C. What do you guys think? Everyone. I want to see a lot of answers.
I didn't understand the question. May you repeat it?
We're talking about you know when your vertebral like your vertebra have like discs in between them, like cartilages in between them. So sometimes for some reason those discs in between herniate or move from their position and they press on the spinal cord. So which part of this disc itself does this compression? Yalla, I want to see more answers in the chat. Or unmute and say the answer. Okay. So okay, everyone's saying no clue. Someone said C. Yes, the answer is C. And I'll explain each one of them. So here, as Rasoul mentioned, when you see this on the slide, that means it's something important that probably will come. So your vertebral disc itself is made up of two parts. You have your, as you can see here, it consists of the nucleus pulposus and the annulus fibrosus. So the nucleus, it's basically the vertebral disc is like a disc, like here, and you have two parts. You have the annulus and the nucleus. The nucleus is basically the part that, sorry, it's the other way around. You have the annulus on the outside and nucleus on the inside. So think about the disc in between the vertebra, and when there's herniation, it moves, and a part of it pushes on the on the disc itself. So usually, on any herniation, the nucleus pulposus is the part that goes out and impinges. You can see here the nucleus pulposus is the part that goes and pushes on the spinal cord, causing pain and muscle weakness and stuff like that. It's recall. You're not supposed to know the anatomy of them that much, but just know that your vertebral disc is made up of two parts. You have the nucleus pulposus and the annulus fibrosus. And when there's a herniation of the disc, the nucleus is the part that pushes on the spinal cord itself. The other 2 points, the dorsal root ganglia and the posterior horn, have nothing to do with, like, they're part of the spinal cord themselves, so they can't compress the spinal cord. So I just added them just to confuse you guys. But the correct answer is the C, nucleus pulposus. It's a recall question, so you need to like memorize the stuff that have the ambulance, because those are the clinical correlation and stuff that they'll ask you on in the exam. All clear? Any questions about the neuro lecture, the nervous system lecture? Because we're moving on to the next one now.
We're moving on to heme.
Yeah, so we're done with the
We're done with
foundation
foundation.
part. If you guys want, we can take a 5-minute break, checkpoint, and then we'll come back, or we can continue. What do you guys want?
So let's continue. Yeah,
Continue?
Okay.
خلاص, continue.
Again, if you guys have any questions in the meantime, let us know. Okay, we're moving on to heme. So attached is a blood smear from a 57-year-old African patient who came for a checkup due to feeling tired after exertion. Which of the following, if any of the pathological cells are present? Okay, so what do we see in this picture, first of all? So what's good with the perfect, yes, sickle cell anemia. What's good with Dr. Rehan's lecture, from what I remember, is the picture he has on the lecture, like in the lecture, are gonna be the exact pictures that are gonna show up on the exam. So it's really, really important to memorize the pictures he posts. Like this one I've seen over the years, every single year, like sickle cell and this exact picture. So it's really important to know, really important to memorize those pictures. So yeah, we see sickle cell anemia. What is present in sickle cell anemia? What's the answer here, do you think? Perfect, yeah. So target cells. Do you guys know what target cells look like?
Yeah, like it's
Exactly, yeah. So it's basically like this. Okay, where do teardrop cells, where are they present? Yeah, exactly. So teardrops are iron deficiency, pencil cells. Yeah, iron deficiency as well. Oh, same thing. And then silk cells are not a thing, but I just put them in there. Yeah. So again, heme, I really, really like heme, and I liked it at first year because it's literally purely you just memorize the picture and that's what comes. So yeah, so this one is pretty, it's just recall. I guess it's African patient here. We kind of know it's like they might be talking about sickle cell anemia. Okay, so I put this picture here to see that there's also this picture that's really high yield as well. It's iron deficiency. You guys were right to say that it has teardrop cells. As we said, they're like this, usually just like a teardrop basically, and a pencil cell. And then they also have hypochromia. Okay, so this is also a very, very high yield picture. So it's either gonna show up like this, or you guys might get that, or we might get both as well. Okay. All right. So what's the function of the cell shown in the picture? First of all, what's the cell? What do we see here? What cell is this? Lymphocyte, yes. And what's the function of lymphocytes? D. Yes. Okay. Now, who can tell me what cell kills bacteria? Yes.
Yes.
Okay. What cell kills helminths? Neutrophils. What cell releases histamine? Yeah, T cells. Okay, and then D we said is lymphocyte. What about the precursor of macrophages? Okay, wonderful. Yeah, you guys are doing good. So yeah, M for monocyte and then M for macrophages. So again, a pretty like I tried to honestly I tried to find hard questions in this lecture, but again, it's morphology. It's purely recall questions. You guys are gonna get the picture and then either gonna ask you about the question about the function or the name of the cell. Okay, now what about this one here? Okay. Yeah. Okay, I know this honestly was an annoying question on my part. This is not a monocyte. Yeah, exactly. This is a band
It's a
cell.
band cell.
This is a left shift. This is a left shift neutrophil. Or a band cell. So monocytes are more kidney-like, so they're more like I don't know how to draw honestly, but like it's more like this. I know this kind of looks like it, but in the lecture, Dr. Rehan has that exact same picture and it has it as the left shift neutrophil. Yes, I know there's no band cell. So another name for band cell is a left shift neutrophil. So that's the answer here. It's a
Left shift just means that it's like it's the stage before it becomes
a
a mature.
precursor.
Yeah, it's before it becomes a mature neutrophil.
Mm.
So it does not have those globules of nuclei. They're still like kind of fused together. So that's why it looks kind of like a monocyte. But monocytes will have like a bigger like it's a bigger like it's like
bigger
a kidney.
body.
Yeah,
It's
it's
a
like
bigger
a
body,
bean
yeah.
or like a kidney.
And it has a smaller indent, 100%. So yeah, so this is the only like tricky question I found that has to do with pictures is the difference between a left shift neutrophil and a monocyte. A monocyte, as Dia said here, or Dia, sorry, yeah, it's a smaller indent. It's more of a kidney-like. A left shift neutrophil, which is a precursor of an actual neutrophil, is just basically like it's those lobules trying to come together. So they're still like in the process of coming together. They're just they're still a precursor. So it's a neutrophil. Does that make sense? Other than that, like it's just straight pictures, straight recall. And mashallah, you guys already know the functions that we went over the last question. You guys have any questions about this lecture? Okay, we're gonna
Okay.
move on to hematopoiesis.
Yes. Wait, monocytes are agranulocytes as well, right? There are no.
Oh yeah.
Yes, that's another thing that you can
Um,
use to differentiate between them.
Yeah, so granulocytes. So I have a mnemonic. It's pretty dumb, but like it's granulocytes are never eat bananas. So never eat bananas. It's neutrophils, eosinophils, basophils. Those are granulocytes. And agranulocytes are the monocytes and lymphocytes. Okay, so that's a really good point. Thank you.
So another way you can differentiate between monocytes and neutrophils, if you see
Yeah,
granules,
yeah.
then it's a neutrophil.
Mhm.
If you don't, then it's a monocyte.
While you're at it, can you like explain about the granules, primary, secondary, and tertiary? Like where can we find primary?
Sure. I'll reach that point when I do the hematopoiesis lecture.
Oh,
It's like, okay. So the first question is the site of blood cell formation or hematopoiesis in an 8-month-old fetus is in which of the following? So is it the yolk sac, liver, spleen, or bone marrow? What do you guys think? Yes, you're right. So bone marrow. It's this here. So I said a 8-month-old fetus. So in a fetus, there are 3 stages. The first 2 months or 0 to 2 months, the hematopoiesis or blood cell formation is in the yolk sac. From 2 to 7 months, it's in the liver and spleen. And then from the 5 to 9 months, I know it kind of overlaps between them, but like just know an older fetus is just closer to like being born and like becoming a baby or an infant outside the mother's womb. So that's
Would the overlap means transition?
Yes, it's basically a transition from the liver to the spleen. So there's a part where both the liver and the bone marrow are both working to form blood cells, but eventually, as the baby gets older, it moves on to the bone marrow and stays there until like you grow up. So from 0 to 2 is the yolk sac, from 2 to 7 is the liver and spleen, and then from 5 to 9 months it's the bone marrow. Why didn't we choose liver? Because the liver is from 2 to 7 months, and I said here it's an 8-month-old fetus. So it's here, 5 to 9 months is the bone marrow. If it was, for example, 3 months old or 4 months old, then liver and spleen could be correct. But because it's towards the older side of the fetus, so it's close to being born, then that's when it moves on to the bone marrow and lots of formation occurs there. Okay, clear? Okay. So next question. Erythropoietin is a growth factor required for the production of RBCs. It's produced in which of the following organs? Yes, you're right. It's a recall question. Erythropoietin is in the kidneys. You have thrombopoietin, it's in the liver, and the rest are the stromal cells. It's a pretty simple question, recall stuff. And then next question, you have which of the following chemical mediators acts on both multipotential stem cells and committed progenitor cells? Yes, you're right. So again, it's a recall kind of question again. There's this table that Dr. Rehan loves, and he asks a lot of questions from it. So the question was, which of the following is common in both of them? And the only one that's in both, in committed progenitor cells and the multipotential, is GCSF. The rest are for like area specific stuff. So I think this is a very, very, very important table that you guys should memorize and focus on. All good? Okay. That is it for the hematopoiesis lecture, but you wanted me to talk about there's one more? Yeah, sorry. Two more, never mind. Okay. So it's a pretty long question. For questions like these, what I usually like to do, it's the same, I think, as Rasoul said. Whenever I see a really long question, I usually just skip the entire thing and go to the last sentence, because in most questions, you can answer it by reading that question. So the prominent color, which is this blue color, of the intercellular structures in some of these cells is likely caused by which of the following? So this, first of all, before we go, do you guys know what these cells are? Yes, you're right. They're reticulocytes. So they're basically precursor for red blood cells. And those blue stuff inside are the remnants of the ribosomal RNA. So you guys were right. Again, it's a recall thing. As you can see here, that this dye, the crystalline blue, stains the remnant of the ribosomal RNA. So this is a thing you can do to differentiate reticulocytes. All good? Clear? One more thing, those are usually found in both the bone marrow and the blood, so that they can ask you about this as well. So where can reticulocytes be found? Bone marrow or blood? They can ask you this stuff, and it's both bone marrow and blood. I think we got this question somewhere. Don't know why I remember something like that. Okay. And then I think this is the last question in the hematopoiesis lecture. A person came to the clinic complaining of a wound that has been bleeding for the past couple of hours, which has not slowed down. After testing, you figure out that there's a problem with the precursor of platelets. So which of the following is affected?
D.
Yes, you're right. Megakaryocyte. So this was the last slide of your lecture. It basically summarizes the entire thing. So lymphoblasts are for lymphocytes, monoblasts are for monocytes, myeloblasts are for granulocytes. So as Rasoul said, the neutrophils, eosinophils, and basophils. Proerythroblasts are for red blood cells, and then the megakaryocytes are like huge cells with multiple nuclei and stuff. Therefore, the platelets. Any question for?
Question. Yes. We said that the only like growth factor that acts on progenitor and like the thing is GCSF. We have also thrombopoietin. It acts on both.
Yeah, but from the choices here, like if thrombopoietin is there, you would have chosen thrombopoietin. But from the choices here, the only one that is in both of them is CGSF. GCSF, sorry. So they
Okay,
usually,
thank you.
no problem. Yeah. So that's it for the hematopoiesis lecture, but someone wanted me to talk about the granules. So give me a second. Let me share screen. Yeah. So basically, remember when we said there are granulocytes? So those granulocytes are called that because they have specific granules inside them that have different like stages of maturation. 1 second. And there's a table here. Okay. So there are three stages for the granules. You have the primary granules, or the azurophilic granules, and then you have the secondary granules, and then you have the tertiary granules. And they tell you at which stage do each of them appear. So as you can see in the slide after it, where is it? Or slide before it? Yes, here. So you have the entire like maturation process of myelopoiesis. So at the beginning, so from myeloblast to promyeloblast to myelocyte, you have your primary granules or the azurophilic granules, which contain those type of proteins. And I think you should memorize this one, myeloperoxidase, which I think is important, and they might ask you a question about it.
Yes, this is the only one Dr. Rayhan told us to memorize.
Yeah. So if they ask you, for example, at which stage does myeloperoxidase like appear in a cell or whatever, then you have to say promyelocyte. So as I was saying, there's like you have a primary, secondary, and then the tertiary granules. The primary granules appear at the promyelocyte stage, and then you have the secondary granules which appear at the myelocyte stage, which is right here. And then you have the tertiary granules which appear at the end, like towards when it becomes a mature granulocyte. Or at the band cell stage towards like the mature stage. So you need to know those types of granules, your primary, secondary, and tertiary. You need to know that myeloperoxidase is found in the primary granules, and you need to know the time that they appear. So you need to know that as the primary granules are at the promyelocyte stage, the secondary are the myelocyte stage, and then the tertiary is at the band cell stage. So that's all you need to know about the granules. And granules are basically those like granules of like proteins or like enzymes that the cell uses to attack other cells like bacteria and stuff like that. Good?
Thank
Clear?
you.
No problem. Okay. So that is it for the hematopoiesis lecture. Now we're moving on to the anemia lecture.
Okay. All right, so we're gonna go straight into it. A 43-year-old man who's anemic with a hemoglobin of 12.2. First of all, what does anemia mean? Like, what do we? What's the disease here when we talk about anemia? Perfect. Low hemoglobin. Okay. So what do you guys know the normal values of hemoglobin? Did Dr. Rehan tell you guys to memorize them? No? Okay. All right, so okay. So if there's low hemoglobin, a person who's anemic has low hemoglobin and an MCV of 70. Is 70 low? What does MCV mean?
Mean corpuscular volume.
Okay, so what is 70 low or is it normal?
It's low because I think it's 80.
So it's 80 to 100. So this means it's low. What does this mean when you're talking about anemia? If we have a low MCV?
There's basically microcytic anemia.
Perfect. Yeah. So we're talking about microcytic anemia. Now the question is, which of the following would most likely be present in this patient? So what do you think the answer here is?
I think it's C, iron deficiency.
Perfect. Yes. So iron deficiency is the only option here that is talking about microcytic anemia. Okay. What is acute bleeding? Which
So I think it's basically bleeding for a short period of time.
yeah. So what is it? Is that yeah, exactly. It's normocytic. It's normocytic normochromic. Yeah. So this one is definitely not the answer because it's here we're talking about a microcytic anemia. Okay. What is folate deficiency? Yeah, macrocytic or megaloblastic. Yeah, perfect. Okay, now what's vitamin B12? Same thing. Okay, yeah. So here we're talking about normocytic anemia, and here we're talking about here we're talking about normocytic, and then here we're talking about macrocytic. So these are definitely not the answers because when we're talking about microcytic, we're talking about iron deficiency only. Is there a different example of a microcytic anemia that you guys know? Thalassemia, yeah. So there's a little table here that we have. You guys don't need to know everything here, but if you guys know a couple and like two in each, then you'll be able to like cross the wrong answers you see on the exam. So iron deficiency and thalassemia, these are microcytic. When we're talking about chronic disease, again here there's some it's in both, but when we talk about chronic disease, it's either microcytic or normocytic. And then microcytic, we're talking about megaloblastic, like vitamin D deficiency. So we're talking about folate deficiency, vitamin B12 deficiency. Here we're talking about megaloblastic. Okay, so if you guys know like two from each, then you'll be able to like answer all the questions that you get on the exam about different types of anemia. Okay, does that make sense? Okay, you're a third year emergency room resident tending to a 48-year-old woman who has come to the ER complaining of increased fatigue and mild shortness of breath. Blood work reveals a hemoglobin of 10. Is that too low? Low. Okay, so we're talking about anemia here. MCV of 76. Is that normal? Is that low? Low. Yeah. And then MCHC of 29 and a decrease in the absolute reticulate count. WBC and platelet counts are within normal limits. And then serum iron and ferritin levels are low, and total iron binding capacity is elevated. So basically, so we have anemia here. We have low hemoglobin. We have low MCV. So it's microcytic again. We have also MCHC of 29, and then we have is that normal? Or is that low for MCHC? Yeah, what do you think of MCHC, guys? Normal, right? Okay. Now the most important thing in this whole example is that ferritin levels are low. Where do we get low levels of ferritin? First of all, do we know what ferritin does? Stores iron, basically. Yeah, perfect. So when we have low levels of ferritin, that means we have low levels of iron as well. So this is like straight. This is straight. Like if we see low level of ferritin, we think of iron deficiency right away. When there's low ferritin levels, that means the level of iron in the blood is also low. And then here we're getting a microcytic anemia. So our findings are all positive of this person having iron deficiency. So iron deficiency here is the correct answer.
Yes.
Does that make sense, guys?
I have a question. We said that the iron is microcytic hypochromic. Yes, iron deficiency.
Yes.
How here is the MCHC is normal.
The MCHC
Yes.
of 29. What do you guys have it in the lecture? Like what's the MCHC and that's the normal value? It's between 27 to 33, right? In the lecture?
No, 33 to 37.
26, 30.
So
Yeah, it is.
yeah,
It's normal. Yeah.
let's go. Here.
It was 32 to 36, I think.
Yeah, so normal MCHC is from 30 to 36, as you said. So it
Yeah,
is
so-
the decrease here.
Yeah, so it's decreased here. I think were you talking about MCH? Maybe you're talking about MCH. The MCH is different than MCH HC.
Yeah.
So MCHC is low here. That means it's hypochromic
Yeah.
as well. Does that make
Yeah,
sense?
it's low because their normal range is 30 to 36, as you said. So it
So
is low.
it's microcytic, hypochromic.
Microcytic, hypochromic, and also we have low ferritin levels. That means straight iron deficiency.
So what's aplastic anemia then?
So aplastic anemia, I think we in your lecture was they talked about it for 2 slides, I believe.
It's basically when there's all
Yeah,
so when
so-
all like
Everything
everything
low.
is low.
So when
So red blood
here,
cells are low.
yeah.
All types of cells are low.
So here they're saying here it's not aplastic anemia. Why? Because they're saying WBC and platelet counts are normal.
So if WBC and platelets were low, then it would be aplastic because
Yeah.
all like it's pancytopenia. So all blood cells are
All
low.
blood cells are low.
Exactly. That's what I was asking.
Yeah.
Yeah.
So if they were saying that the platelet counts in WBC was low, then it would be aplastic anemia. Does that make sense?
Yeah, it makes sense. Thank you.
Again, yes. The most important thing we need to know here, this could also be like part of this could be also your SAQ, guys. Like one of those cases like anemia, for example, this could be one of your SAQs. So what's important to like it's good to know like the ones that are specific, the facts that are specific to some diseases. So iron deficiency, what's specific to it is low ferritin. So that is very, very high yield. If it comes on an MCQ or SAQ, it's really important to mention that they have low ferritin. Okay. A healthy 3-year-old girl is brought to the emergency department because of severe uncontrolled nosebleeds. She has a history of ear infections that has improved after treatments. Her temperature is elevated. She has numerous small bruises on her arms and legs. Her laboratories show empty bone marrow. Hemoglobin, is that low or is that normal?
That is very low.
Very, very low. Yeah. So again, we're talking about anemia here. So leukocyte count is 3,000. Normal is 5,000, 7,000. That means leukocyte count is low. Reticulocyte is 0.1. Do you guys know what the normal is?
I think it's above 2, I think.
0. Yeah, so I think it was 0.22. I don't remember exactly what your lecture is. This also, you guys need to know if you guys need to memorize those normal values or not. Like you guys need to ask Dr. Rehan if she's going to be providing normal values. Okay. And then platelet count.
He mentioned we would be getting the normal values as well.
Okay, then perfect. Then you guys are good. Yeah, because I remember for us we had them. Yeah. Okay, so platelet counts is 12. Normally is 150 to 400, so also very, very low. What's the answer here? What do you guys think?
So here, every single type of
I
blood
think
cell.
it's sickle cell disease.
So why do you think it's sickle cell? We didn't talk about MCHC here. So sorry, yeah, we didn't talk about MCHC. We're talking about leukocytes, reticulocytes, platelets. They're all low. So would that be low in sickle? Where would that be low when we have everything?
They also here
aplastic anemia.
yes, they also
Yeah,
mention
they
a
also
keyword
mention-
here, which
yeah.
is the empty bone
Empty
marrow.
marrow is very high yield as well.
So it's like a trigger word or for aplastic anemia.
Yeah,
If
so
you hear
when
it,
there's empty bone marrow, we're talking about aplastic anemia.
But like leukocyte doesn't it like come during an infection?
Leukocytes?
Yes.
Yeah.
So
Um,
like then there's supposed to be like some kind of infection going on in the blood. That's why I assumed it was sickle cell disease.
here it's the point of them mentioning an infection is that like they're giving you signs that they have, for example, here the uncontrolled nosebleeds. It's saying that there are low platelets. It's saying that there are history of ear infections, saying that the person is immune deficient, so they have less white blood cells, as well as the other stuff like the low hemoglobin and stuff like that. All of these point that there is a low amount of all types of like white blood cells or like blood cells in general. So that's why you go for aplastic anemia. Even like they're saying that she has an infection, but even though she has an infection, you have a low count of white blood cells. So all of these point towards something wrong with the bone marrow causing the aplastic anemia.
Makes sense. Thank you.
No problem.
there's I hope I have it right here. So yeah, aplastic anemia is pancytopenia. So when everything like we said is low, so when platelets are low, leukocytes are low, white blood cells, everything is low. That's when you're thinking aplastic. Hypocellular. I think there's 2 or 3 pictures, or empty, same thing. There's 2 or 3 pictures that you guys have in your lecture, that shows what empty bone marrow. This is also very high yield. You guys need to be able to notice which one is empty bone marrow when we're talking about aplastic anemia. It might be important for your OSPE or your MCQ as well. So when we see a hypocellular, which means just very low count of cells, or empty, then we're empty bone marrow, then we're talking about aplastic anemia. Okay, we're gonna move on to blood groups.
Yes. Before you do that, do you have any questions for
Yeah, do you
anemia?
guys have any questions?
I have a question for both 30 and 29. But let's start with 30.
Okay.
If empty bone marrow wasn't mentioned, would the answer be A? Because she said nosebleeds, uncontrolled nosebleeds.
The uncontrolled nosebleeds, as I said, was trying to move you towards the no platelets, not the blood loss, because uncontrolled nosebleeds, that means there's no clotting, so the platelets function is not working. So I think even if empty bone marrow is not mentioned, it would still be
It would
aplastic.
still, because first of all, also the definition of anemia of blood loss is that the hemoglobin would be normal at first in the beginning, and then after 2 or 3 days we see reticulocytes. So here we didn't see any
Even the reticulocyte count is also low.
low. Yeah, so reticulocyte is low. They didn't say anything about her coming in with the normal hemoglobin, because we said that so she had severe uncontrolled nosebleeds, and that's why she came to the hospital. It didn't say that this happened this happened right now, and it didn't still showed low hemoglobin.
Yeah, and also there's the other stuff like the infections and stuff like that, pointing towards that it's not just the the red blood cells, it's also white blood cells and stuff like that. So all of these point towards entire bone marrow not functioning.
That's clear. But for question 29,
Yes.
so the question here was, why isn't it a chronic disease? Like if ferritin levels also weren't mentioned, would it be A also?
Okay, again, so in chronic disease, was that hypoproliferative? Yeah, and chronic disease, or is it? Yeah, it's right here. Yeah. So anemia of chronic disease. So if it wasn't mentioned, if let's say low ferritin levels and this, so they said serum iron and low ferritin levels. Let's say they didn't mention that, then it would be like it would kind of be like a misleading question, to be honest. Because
Yeah.
when we're talking about we're talking about hypochromic, microcytic, microcytic hypochromic. In the options, we have two. We have iron deficiency and we have anemia of
Anemia
chronic
of chronic
disease.
disease.
So this would be a misleading question. Let's say iron deficiency wasn't part of the answers,
Then
and
yes,
there was
it
no
would be-
lower ferritin, no low serum iron, then that could be the
Yeah.
answer. But because those two options work in that situation when there's no low ferritin, so yeah, it would. I don't think they would give you questions like that.
Yeah.
Like they wouldn't give you a question with two answers. That could be correct.
Yeah, because if it wasn't then it could be both of them, and you need more details to be able to answer the questions. I don't think they will get you something like that.
All right, thank you.
Okay, any more questions for anemia, or do we move on to blood types?
Yes, may we like say what the proliferation cases and the hyperproliferation cases?
Sorry, what about the hypoproliferative cases?
Can we list them? Like for example, I want to make sure that IDA, for example, is a hypo, B12 and folate acid, folate, whatever, يعني, it's also hypo, right?
Yeah,
Aplastic.
aplastic is one of them. Anything with the anemia that happens due to chronic diseases, so like renal disease or cancers, any type of anemia that happens through that would be hypoproliferative. Iron deficiency, as you said, all these are part of hypoproliferative anemias. Yes.
How about hyper?
How about what? Sorry.
Hyper.
So hyper. So, did you guys talk about hyperproliferative?
Yes,
Yes, you did. They're basically
it's either if it's hereditary diseases,
Yeah.
so like beta thalassemia, thalassemia,
So-
sickle cell, stuff like that,
sickle cell.
and or the G6PD deficiency, or if it's acquired like immune hemolytic anemia, stuff like that.
So anything that you get, anything that's like genetic
Genetics,
disease,
like the
diseases.
thalassemias and G6PD
These
deficiency,
are all
or
deficiencies
immune
that you
stuff.
get. Yeah. So it's basically that you don't need to know all the examples again. If you guys know sickle cell and thalassemia are hyperproliferative, then
Proliferative.
proliferative. Okay, never mind. You guys know this is hyper, then sickle cell and thalassemia. That's all you need to know. You guys don't need to know all the examples for it, and he won't ask you other than what he brought up in the lecture, which would
Yeah.
probably those two, right? Or
Just like look through the slides again if you're not sure of them, but like anything that's like more hereditary stuff or like immune stuff, then it's the hyperproliferative. If it's chronic disease or aplastic and stuff like that, then it is hypoproliferative.
Okay, thanks.
No problem. Okay, so now we move on to the blood types. So it's a pretty simple question. What do you think this blood type is? A positive. Do you guys know why it's A positive? Let's walk through.
A antigen is up, and the D antigen is up as well. So both of them, which means that both of them is positive.
So if you see here in the tubes, if the blood is at the top, that means there is a reaction that happened. If the blood's at the bottom, that means there's no reaction that happened. So here in this tube, there is anti-A antibodies, and then you add the patient's blood. So when that happens, then there is a reaction that happens causing it to be at the top. So when you see this, that means that it's an A group. And then you look at B is at the bottom, so there's no B antigens. So it's an A blood group. And then you look at the D or the RH tube. The RH tube is also at the top. That means there was a reaction that happened. That means that it's A positive. As you can see here, if you see the blood is on the top, that means there is a reaction. If it's at the bottom, that means there's no reaction. And then you look at the tube. If you see a reaction, the first one here, that means it's an A blood group. And if you see a reaction here, that means it's a D blood group. And another thing you can do is that you can look at the last two tubes as well. Those last two tubes are the opposite. You have the patient's serum inside the tube, and then you add blood cells to it. So you add A blood cells and then B blood cells. If there is A blood, you see the A blood cells are at the bottom. That means the patient's serum does not have anti-A antibodies. But in the last tube, you see that there's the blood is floating at the top. That means that the patient's serum has the anti-B antibodies. So you have two ways of doing it. The first way, there is in the first tube, the tube itself, without the patient blood, the first one has anti-B. Sorry. The first tube has anti-A antibodies. The second tube has anti-B. The third group has the anti-D or anti-RH. So that in that case, if there is a reaction, that means the antibodies in the tube, like the agglutination, or like they form the reaction with the blood itself. So if there's a reaction in the first tube, that means the anti-A antibodies attack the A blood group in the patient. That means it's it's an A blood group. And then the same thing for D. So there's two ways you guys can do it, as you can see here. And there was a video in Dr. Rehan's slide that explained this well. So if you guys still don't get this, ask me, or you can go back to that slide, because they're gonna ask a lot of questions from this, whether in the MCQ or the OSB. I remember when we did HLS, they asked a lot of this question.
Yeah.
What would it look like for an A negative? An A negative will have the same thing for those two tubes and the same thing for those two tubes. The only difference is that here in the RH tube, the blood would be at the bottom here, because there won't be a reaction. So if there's blood at the bottom here and there's nothing at the top, and there's this exact same thing, then it would be an A negative blood group. Is that clear? Okay. The next question is, an RBC with N-acetylgalactosamine belongs to which blood group? Yes, this is perfect. So if there was what sugar will be there if it's a B blood group? Galactose, you're right. And if it's an AB? Yes, both. And if it's an O? Yes. So this is the slide that shows it. If there's N-acetylgalactosamine, then it should be an A. If there's galactose, then it should be a B. If they're both, then it's an AB. If there's none, then it's an O antigen. Is that clear? Okay. And then the last question for the blood group structure. Which of the following transfusions will cause an immediate reaction in an individual receiving blood for the first time? This is very important, for the first time. I'll explain why it's important for the first time. You're all saying E. Yes, you're right. Okay, so let's go for the on the answers one by one. The first answer says you're giving an RH negative to an RH positive. An RH negative is a universal donor, because anything that's negative can be given to a positive, and O can be given to all blood types. So an RH negative is given to an RH positive, that will cause no reaction. An AB negative is given to an AB positive, that will also cause no reaction, because if a negative is given to a positive, that will be fine. An O negative is given, an O positive is given to an A negative patient. We said that positive given to a negative will cause a reaction, right? Then why is C wrong? Why wouldn't C cause reaction?
Because
guys
O
know?
is a universal donor.
No, but O negative is a universal donor. But we said here O RH positive given to an A RH negative. This should cause a reaction, but why didn't it cause a reaction in this case? Yes, you're right, exactly. Because the question said for the first time, then this wouldn't cause a reaction. It would cause a reaction if it's between like different blood groups. So a B giving to an A, stuff like that, this would cause a reaction. But for the for the RH antigen to cause a reaction, the body will need to get exposed to the RH positive for the first time, and then it would form the antibodies, but it wouldn't cause a reaction. The second time, if you give a transfusion to a patient who is Rh negative, if you give them Rh positive for the second time, that is when it would cause a reaction. So that's why I said for the first time sentence in the question is very important, because if it's not there, then both C and E can be correct. But because they said for the first time, this is the reason why it wouldn't cause a reaction. It would just cause the formation of antibodies, but it wouldn't cause a agglutination reaction. And then D, Rh negative B is giving to Rh negative B. That's fine. You're giving the exact same blood. And then E, Rh negative A is given to an Rh negative B. As I mentioned, if it's different blood groups, then it would cause a reaction from the first time. But if it's a negative if it's a positive to a negative, then it needs the second reaction to cause the second transfusion to cause a reaction. So the first one, the antibodies form. The second one, the reaction will happen. That's for the negative positive thing. Is that clear? Good?
Yeah.
Okay.
Then we have
That's a table that will show the compatibility. Okay, now we're done with the blood types. We move on to leukocytes.
leukocytes.
We have two more lectures.
Two more lectures. Bear with us, guys. We're wonderful. All right. 6-7-year-old female presents with pallor and splenomegaly. CBC revealed an elevated WBC of 128. Which of the following features in peripheral blood picture would suggest a diagnosis of acute leukemia? So here's a second. Here's an example of we don't need all of this. We can just be like, which of the following features in the blood picture which would suggest a diagnosis of acute leukemia? Like, what do we need to show that it's acute leukemia? You guys know? Okay, I'm gonna go through the lecture here.
Yes.
Yeah, so it is deep. So this is also I wanted to find something that the doctor could ask about. So here when we talk about acute leukemia, it basically defines as the increased the levels of white blood cells, okay, or blast cells. And so the increase in blast cells is indicative of acute leukemia. So here the only thing that would make sense is blast cells. And then we have different types of leukemia. We have lymphatic leukemias and myelogenous leukemia. But what we need to know is that what we need to identify this disease as acute leukemia is a high number of blast cells. So this is just a recall question I found. But I also think that's very, very high yield. Now here, if they were talking, if we found instead of leukemia, it was white blood cells, then instead of blast cells, it was white blood cells, then that would be the right answer. Does that make sense?
So blast cells is just a different name
Different
for
name.
abnormal white blood cells. So it's just something you need to know just in case they ask you in the exam. So in acute leukemia, it's a problem with the white blood cells. It's abnormal white blood cells. But another name for them is blast cells, and we thought it's a high yield concept that they might ask you about. So it's just something good to memorize and know about the lecture. Okay. All good?
Okay. Now, in which of the following condition will this cell be seen? First of all, do you guys know what this cell is?
Or what do you find nuclear services? So nuclear RBCs are basically immature RBCs or RBCs before they lose their nucleus. So it's a precursor of the RBCs.
Oh, sorry, I didn't see that. Yeah. Immature neutrophil. Yeah, perfect. So where would we find immature neutrophils? There's a couple different examples you guys had in your lecture about different examples of where we can find immature neutrophilia. Again, this is also a tough question on my part, but in the lecture, again, because this is a like relatively easy lecture. I was trying to find questions that could actually like the doctor could bring to trick you. So like in the lecture here, they say where can immature neutrophilia be found? Bacterial infection, so not viral, it's bacterial, inflammation, severe anemia, and bone marrow infiltration, which is also known as chronic myeloid leukemia. Yeah.
I want to ask a question. Immature neutrophilia. The doctor said it's viral infection. How is here it's written bacterial infection?
In immature neutrophilia,
Yes.
in the lecture, so this is from Dr. Haddad. He has this bacterial infection. Searched it up and they were only talking about bacteria. I'm not sure if he said it. I don't know if he was talking about something else, but like in the lecture he says bacterial infection only. I'm not sure if the viral infection is part of it too. I believe it's only bacterial because this is 34. Yeah, it's a recall question. So question 34, yeah, it's a recall question. He has it in the slides. And also 35. So 35, you would just need, first of all, it's not purely recall because you guys needed to know what immature neutrophilia is. But you need to know different examples of it, which is here, chronic myeloid leukemia. Who asked the question? Was it Malak? I'll get back to you on the viral infection, but in the lecture he only uses
Yeah,
bacterial.
I think it's for bacterial infection. Neutrophils are like specified for bacteria.
Yeah.
So neutrophilia are
Viral is helmet, right? No, that's
viral is lymphocytes.
lymphocyte.
Yeah. If there's immature neutrophilia, that means your body is making as much neutrophils as possible in order to fight this infection. And I think neutrophils are specific for bacterial infections. This is why you would have immature neutrophilia and bacterial infections. For viral infections, I think it's lymphocytes, not neutrophils.
Yeah, and even in the lecture he has it as bacterial infection. So yeah. I'll get back to you on that. Okay, a 5-year-old patient presents to the ER with a 2-week history of diarrhea. He is admitted for dehydration. His stool specimen is positive for parasitic eggs. The cell elevated in this patient has which of the following characteristics? So, first of all, which of the cells have parasitic eggs or 5 parasitic eggs?
Eosinophils, yes.
Eosinophils, perfect. Okay, so now what's a characteristic of eosinophil? So does it differentiate into macrophages? So
What cell is
what cell differentiates into macrophages?
Yes.
Monocytes. Yeah, so this is not it. It's a bone marrow derived lymphocyte.
Are eosinophils bone marrow derived? What do you guys think?
Bone marrow? B cell, yeah, B cell.
Yes.
And then composed of natural killer cells.
What would natural killer cells be? Which type of cells? Lymphocytes, yes.
Okay. And then it releases nitric oxide or
Major basic protein.
major basic protein.
What cell would be that?
That's yeah,
That is
eosinophils.
the answer, yes.
And then what's the highly motile phagocytic cell?
What cell would do phagocytosis?
Macrophages. Or yeah,
Neutrophils and macrophages.
macrophages, yeah. So
So the
here
answer for this would be
D, which is the eosinophils which usually fight parasitic eggs.
parasitic eggs.
When we have
parasites.
it's also in a lecture. It's directly says contains nitric oxide and major basic protein, and it also has defense against parasites. So again, yeah, a recall question, but it's very, very high yield to know like those different stuff. So the different functions, and then how they look on like and how they look on stool and what they release. It's really high yield to know that, guys. All right, I think we're past the last.
I have a question. Sorry for the
Yes.
interruption. Here is eosinophil. It's allergic, involved in allergic reaction, right? And we said also like basophils are also involved in allergic reaction.
Yes.
Mhm.
So both of
what should
both of them are allergic reactions, but when we're talking about parasites in specific, that's when you talk about eosinophils. But if we're talking about allergic reactions, both eosinophils and basophils are involved.
So here
Okay.
the hint was parasitic. If it's parasitic, that's eosinophils right away.
Yes. Okay.
All good. Now we're moving
Down
on
to
to
our
the last lecture.
last couple questions.
So this lecture is hemostasis or blood clotting. So the first question is, a 1-year-old boy presented with prolonged bleeding after circumcision.
C.
Respiratory investigation shows bleeding time of 5 minutes. So bleeding time is normal. There's the prothrombin time is 10 seconds, which is also normal. And you have the activated partial thromboplastin time, or APTT, is 120 seconds, which is way above the normal. So it's prolonged APTT. So which of the following will most likely be the cause of this? So APTT, does it measure intrinsic or extrinsic pathway? Yes. So which of the following clot factors is in the intrinsic pathway? You can see it here. You're right. You guys were right. It's A. So if APTT is prolonged, then it's a problem with either factor 8 or either factor 8 or factor 9. The way I memorize it, if it's like APTT or PT, PT is 1 T, APTT is 2 T's. You play tennis outside your house, so PT is for the extrinsic factors. You play table tennis inside your house, so APTT is an intrinsic factor. Okay, clear? Okay. The next question, which of the following procoagulant protein binds to tissue factor and initiates the clotting cascade? What do you guys think? A. Yes, you're right. So as you can see here, the tissue factor is right here in the extrinsic pathway, and factor 7 is what binds to it to initiate the cascade. It's a recall question. You just need to know the pathways and what is inside them. Like the clotting factors are inside them to know the cascade. And then moving on to our final question. A 6-year-old girl is brought with a history of epistaxis since birth. Her laboratory investigations show a hemoglobin of 10.5, which is normal, white blood cells of 6.5, which is normal, platelet count of 350, peripheral blood smear shows normal platelets in morphology, bleeding time is 12 minutes, so she has prolonged bleeding time. PT is 11, which is normal, APTT is 30, which is normal. So which of the following is the problem? So if PT is normal and ABTT is normal, that means the problem is not with the clotting factors, it's with something else. And we have a prolonged bleeding time. So what do you guys think the problem is? Yes.
I think it should be B.
Yes. So prolonged bleeding time is associated with problems with the platelets. So if you see that the PT is normal, the ABTT is normal, but you have a prolonged bleeding time, then it's most likely a problem with the platelets. So here, prolonged bleeding time is a problem with platelets. And that is all the questions we have for you guys today. If you have any questions, let us know. And you can also feel free to email us whenever you want if you have a question. And yeah, that's it. And
You guys have any
do
questions
you have any questions for us?
Do you have any tips for the exam?
for the exam?
Yeah.
Okay, I think
Okay, I would say one important tip other than the studying is to read the questions very, very carefully, once, twice, 3 times, and make sure you understand what they want from the question, because sometimes the wording might like mislead you or like make you think that they want something when it's something else that they want. So make sure you read the questions carefully, and
especially in OSPI.
especially in the OSPI, and you like know what they want, and like as Rasoul said, when you approach a question, read the answers, know what they're trying to get out of your question, then go to the last sentence of the question, read it, try to understand what they want, and then if you need more information, you can go through the entire thing.
Again, yeah, also I feel like what something that's really underrated, I feel like not a lot of people talk about is your sleep. So your sleep really matters the night before the exam.
Yes.
I really like, even if you think you're behind, if you think you need to do some questions, getting a good night's sleep is really, really important, especially if you have an exam that is what, 3-4 hours with OSPI and everything. Yeah, so I think you need to get a good night's sleep. That's really, really important. We have a question about the recall question. So what we tried to bring wasn't just recall. What we had was like, for example, it was 2-step questions. For example, like you would need to know the function, what this thing is, and then know the function of it.
But generally, because our session today was about anatomy, generally anatomy most of the time will be like recall, or as Rasoul said, a 2-step question. So you need to recall 2 things at the same time to understand it. The more thinking questions and stuff that you like need to like analyze the question and stuff is more physiology and those stuff.
Yeah,
but anatomy tends to be like recall questions generally.
For ANS, I think I tried to go over most of the things you need to know for ANS. For ANS, you need to know what the differences between those two, and I brought a question about that. And you need to know the function, what they do. So one is rest and digest, one is fight or flight. So if you know that much, I think you'll be set. You just gotta go through it one last time, the lecture. But I think if you know the differences and you know what each one does, you're basically
you just need to know like the parasympathetic, sympathetic, how they differ, like the neurotransmitters, and then their function, like the fight or flight stuff.
Yeah. Should I focus on past papers?
Yes.
Yes.
Very, very important.
So I think it's pretty important to go over past papers. Although like this year, especially, you guys have a different system than us. So like also keep that in mind. You guys, like for heme, for example, you go through our heme lectures. Our heme lectures are not the same as the ones you guys took. Like I think you guys took a more simplified lectures than us. We took way more anatomy in our actual heme block. So keep that in mind. Like some stuff will not be assessed on you guys' exam.
Yeah. So like you're gonna have to go through both exams, the foundation and the HLS finals, but command they removed some of the stuff from the lectures, so you might see stuff that you think you didn't study, but they probably removed it.
Yeah.
So you need to be careful with studying them, but I believe that they're very, very, very important. Both the HLS and
you guys like go through 14th batch as well. Like go through our batch drive. If you don't find what you need to find in other batch drives, go through ours as well. See, like check other hours, 15th batch, check those.
Yeah, I would say like try to solve up to 13th batch, stuff like that. So 13th, 14th, 15th batch.
Do we have a mock before them? I feel like we didn't have
I don't think
for foundation last year. This year they're doing it because MSA stuff was pretty quick, so I think they did it right away.
I would say if you can attend it, because it would be helpful.
Yeah.
And
I have a question.
yes.
You mentioned that in Dr. Rayhan's lectures, the pictures usually come copy-paste, the same ones. So is it the same with the Dr. Khalid's histology lectures?
Histology lectures
I
is
don't
more
think so.
lab.
I don't think so, no.
You need to focus on lab. For history, focus on the lab pictures.
Like the lab pictures, they'll get you stuff from the stuff you took in the lab, not from the lectures themselves. But for Dr. Rayhan, I think most of the questions that he's gonna get, if he's gonna get pictures, they would be from the slides, so that you can like.
Yeah.
All right. If I can get you guys to scan this QR code, please.
It's a quick survey.
Quick survey for ours, for us, because it helps us also like improve for future PAL sessions as well. Okay. You guys have any questions?
Is there a certain pattern that a doctor asks a question from? Like,
sorry?
Is there a certain pattern that the doctor asks a question?
Let's stop the recording so we can. Is Ayman here still?
Yep, right here.
We can stop just for the questions.
Okay.
please.